Hello friends, welcome to my YouTube channel. Today I am going to study part 2 of ear starting with cholesteatoma. First is a case presentation. Otoscopic image of a patient with a history of repeated middle ear infection showed presence of large mass of white keratin debris in the left upper quadrant of the left tympanic membrane. This clinical scenario is suggestive of cholesteatoma, which is also known as epidermosis or keratoma. Cholesteatoma is the presence of stratified squamous epithelium in middle ear where it is not usually present, that is, skin in wrong place. A central white mass consisting of keratin debris is produced by the matrix. For this reason, it has been named as epidermosis or keratoma. The term cholesteatoma is a misnomer because it neither contains cholesterol crystals nor it is a tumor to merit the suffix -oma. The middle ear is not lined by keratinizing squamous epithelium and hence its presence anywhere within the middle ear cleft is considered cholesteatoma. Various kinds of epithelia lining the middle ear are ciliated columnar epithelium, which is around the eustachian tube opening, that is protympanum, pavement-like, which is present in atic or epitympanum, cuboidal epithelium, which is present in rest of the part. Next is a case presentation. You see a patient with history of painless, foul-smelling ear discharge and loss of hearing for the past year. He had undergone tympanoplasty on the same ear 3 years back. The given clinical scenario suggests a diagnosis of secondary acute cholesteatoma. The history of middle ear infection and hearing loss after surgery of the tympanic membrane makes the diagnosis more likely. Classification of cholesteatoma are congenital cholesteatoma, which has its nidus of trapped squamous epithelium present at birth. Primary acquired cholesteatoma presents with no history of previous otitis media or a pre-existing perforation. It is associated with a defect in pars flaccida. Secondary acquired cholesteatoma presents with history of previous otitis media or pre-existing perforation. It is associated with a defect in pars tensa. Next is tertiary acquired cholesteatoma, which is defined as that which occurs behind a normal appearing tympanic membrane as the result of implantation of an antecedent middle ear inflammation. Theory associated with congenital cholesteatoma is congenital cell rest. Theory associated with primary acute cholesteatoma is Whitmack's theory of retraction pockets, Rudy's theory of basal cell hyperplasia, Sadie's metaplasia theory. Theory based on secondary acute cholesteatoma is Haberman's theory of epithelial invasion, Sadie's metaplasia theory. Cholesteatoma can be of two main types, that is congenital cholesteatoma, which is explained by the presence of congenital cell rest within the middle ear and other parts of the temporal bone. Acute cholesteatoma is explained by a pathology either within the mastoid air cell system and eustachian tube drainage or the tympanic membrane epithelium. The most accepted theory for secondary cholesteatoma is Haberman's theory. It proposes that the skin of the external auditory meatus grow or migrates into the middle ear through the postero-superior marginal perforation or atic perforation, forming cholesteatoma. Prusac space is the most common site of primary cholesteatoma. It is the space in the epitympanum lying in between pars flaccida and neck of the malleus. Next is a case presentation. 8-year-old boy was referred to an otolaryngologist for subjective left-sided hearing loss. A hearing test revealed mild conductive hearing loss at low and middle frequencies. Otoendoscopy showed white pearly mass behind the intact eardrum in the anterosuperior quadrant, which is suggestive of congenital cholesteatoma. Levinson criteria should be satisfied in order to diagnose this condition. Levinson criteria include a white mass behind the normal tympanic membrane, normal pars tensa and pars flaccida, no prior history of otorrhea, no prior history of otological procedure, episodes of otitis media with effusion, which should not be considered as exclusion criteria. Cholesteatoma does not cause bone destruction by pressure necrosis. Bone destruction by cholesteatoma has been attributed to enzymes liberated by osteoclast and mononuclear inflammatory cells such as collagenase, proteolytic enzymes, and acid phosphatase. Pediatric cholesteatoma has more inflammation and greater chance of ossicular erosion compared to adults. However, pediatric cholesteatoma has lesser chance of petrous labyrinth invasion and lateral semicircular canal fistula formation. Residual cholesteatoma is most likely to be seen in the sinus tympani. The involvement of the sinus tympani along with posterior mesotympanum is a recognized risk factor for residual cholesteatoma. This is because it is particularly difficult to remove the disease from these areas. Canal wall-up procedures have a high risk of leaving residual disease behind than the canal wall-down procedures. Sinus tympani or infrapyramidal recess is the medial of the two posterior spaces in the middle ear. It is bounded by pyramid and vertical segment of facial nerve laterally, the stipes and oval window medially, ponticulus superiorly, and subiculum inferiorly. Tubotympanic type of CSOM is considered to be safe type in relativity to atticoandral disease, as tubotympanic type has less chance of complications than atticoandral disease. Tubotympanic disease can lead to complications, but the incidence is much less than that of atticoandral disease. Next is classification of CSOM, that is tubotympanic as well as atticoandral. Tubotympanic type of CSOM in detail. It is also known as safe type. Recent name is mucosal variant. Discharges are profuse, mucoid, non-foul smelling, non-blood stained. Site of tubotympanic CSOM is mostly it is in the protympanum, that is part of middle ear around the eustachian tube orifice. Perforation is central perforation, which is most common in the anteroinferior quadrant. Granulations are uncommon. Polyp is pale and it is rare. Cholesteatoma is absent. Complications are rare. Treatment includes medical treatment or surgical treatment. Surgical treatment is tympanoplasty. Next type is atticoandral type of CSOM. It is also known as unsafe ear. Recent name is squamosal disease. Discharge of atticoandral CSOM is scanty, purulent, foul smelling, may be blood stained. Site of atticoandral CSOM is it mostly involves the epitympanum or attic and involves the mastoid antrum via the adytus. Perforation is attic perforation, that is in the pars flaccida, or marginal perforation, which is the most common and present postero-superiorly. Granulations are common in atticoandral CSOM. Polyp is fleshy red and common. Cholesteatoma is present. Complications are common. Treatment is always surgical, that is mastoidectomy. Next case is the otoscopy finding in a child with poor scholastic performance showed subtotal perforation. It involves all four quadrants of the tympanic membrane, but it is covered by remnant pars tensa or annulus all around. Chronic suppurative otitis media is the single most important cause of hearing impairment in rural populations. Children with CSOM have poor academic performance. Types of tympanic membrane perforation is pars tensa perforation, which is also known as tubotympanic disease, and pars flaccida perforation, which is also known as atticoandral disease. Next case is a young adult presented with intermittent non-foul smelling mucoid discharge from the left ear for the past few years. Otologic examination revealed a central perforation of the tympanic membrane. The clinical scenario of intermittent mucoid discharge and central perforation of the tympanic membrane points to a diagnosis of tubotympanic type of CSOM, which is not associated with cholesteatoma. Atticoandral type is associated with cholesteatoma and it leads to dangerous complications due to its bone eroding properties. Etiology of tubotympanic type of CSOM, that is benign or safe type of CSOM, is as a sequelae of acute otitis media. We can see tubotympanic CSOM, and other causes are allergic conditions, ascending infection via the eustachian tube. Bone destruction is not present in this type. Culture reveals mixed aerobic and anaerobic infection. Oral polyp, if present, should be removed and not avulsed before starting local treatment. This is due to the fact that the polyp may be arising from the stipes, facial nerve or horizontal canal, and its avulsion can lead to facial paralysis or labyrinthitis. Next case is a known case of tubotympanic disease was taken up for surgery, and on examining the middle ear, few chalky white deposits were found between the ossicles. The given clinical scenario is suggestive of tympanosclerosis. It is a sequelae of long-standing middle ear disease where there are hyaline deposits within the middle ear which calcify, leading to impaired mobility of ossicles. The common sites are tympanic membrane, promontory, ossicles, joints, tendons, and oval and round windows. When hyalinization and calcification involve only the tympanic membrane, it is known as meringosclerosis. Next case is a first year ENT PG sees a child with permanent perforation of the tympanic membrane. A permanent perforation is lined by squamous epithelium at its edges, hindering spontaneous healing. Features of permanent perforation are: it is seen in CSOM, it is similar to an epithelial lined fistulous tract, it cannot be medically managed, thus mandating surgery. Next case is a young adult presents with a 3-year history of intermittent ear discharge. He complains of poor hearing which improves during discharge periods but is worse when the ear is dry. The given scenario describes the round window shielding effect that is seen in tubotympanic type of CSOM. The round window shielding effect is where the ear discharge shields the round window from sound waves. During the inactive phase, that is when there is no discharge, the sound strikes both the oval window and round window together and the noise cancels itself out. So the hearing is worse when the ear is dry. Choleosteatoma hearer is a patient with a discontinuous ossicular chain, but the sound is conducted through the choleosteatoma to the foot plate. On removing the choleosteatoma by surgery, the patient has worse hearing. Next case is a patient with chronic suppurative otitis media is posted for surgery. Pre-operatively, the surgeon wants to assess the status of the ossicle so that he can be prepared for ossicular construction if required. The patch test is useful in assessing the status of the ossicles pre-operatively so that the surgeon can be prepared for ossicular reconstruction if required. It is done in tubotympanic type of CSOM. A thin paper-like cigarette foil is soaked in Vaseline and cut into the size of perforation, and it is used to close the perforation. Pure tone audiometry is done before and after the closure of perforation. Results are as follows. If the patient has improved hearing, that is intact ossicular chain, decreased hearing means the ossicular fixity is present or there is discontinuity. If there is no improvement, it is due to technical fault or improper hearing. Another test done in the tubotympanic type of CSOM is Bonson's test. When the eardrum is painted with 1 in 20% solution of silver nitrate, the perforations stand out as a black spot against a white background. 9-step test is used to predict the ears at risk of middle ear barotrauma. The side-step test and the Unterberger test are vestibular test which is positive in perilymphatic fistula. Central perforation in the anteroinferior quadrant of tympanic membrane is commonly seen in tubotympanic type, while marginal perforation in the posterosuperior quadrant is commonly seen in atticoantral type of CSOM. Bloody, scanned, foul-smelling ear discharge, ear pain, hearing loss, and tinnitus are often seen in the atticoantral type of CSOM. Atticoantral type, it is also known as unsafe or dangerous type, involves perforation of shrapnel's membrane or pars flaccida, that is attic perforation. The disease is often associated with bone eroding process such as choleosteatoma, granulations, or osteitis. The risk of complication is high in this variety. Tympanoplasty is the most common surgery done in the tubotympanic type of CSOM. It involves ossiculoplasty, that is the eradication of the disease from the middle ear and repair of ossicles, with or without meringoplasty, that is repair of perforation of the tympanic membrane, which is done to check repeated infections from external ear. That is tympanoplasty. In short, it involves ossiculoplasty with or without meringoplasty. Next is a case. As a first-year ENT resident, you are preparing a patient for tympanoplasty. In this case, CT scan of the temporal bone is not required in tympanoplasty procedures. It is required only in case of mastoidectomy. For tympanoplasty, routine blood investigations, pure tone audiometry, and an X-ray of the mastoid are sufficient. Zollner and Wallstein's classification is used to classify tympanoplasty. Types of tympanoplasty according to Zollner and Wallstein's classification in detail. First is type 1 tympanoplasty, which is also known as meringoplasty. Here all the ossicles are intact. Procedure is graft is placed over or under remnant tympanic membrane over the handle of malleus. Next is type 2 tympanoplasty. Here malleus is eroded. The graft is placed over the remnant malleus or incus. Next is type 3 tympanoplasty or columella or meringostepediopexy. Here malleus and incus are absent. Graft is placed over the stepy superstructure. Next is type 4 tympanoplasty or cavum minor. All ossicles are eroded. Graft is placed over eustachian tube and the round window, leaving mobile footplate exposed. Type 5 tympanoplasty or fenestration surgery. That is, here the footplate is fixed and an opening made in the lateral semicircular canal where the graft is placed. Next is type 6 or sono inversion. Here the round window is left exposed and receives sound and the oval window is covered. This is a reversed pathway. Type 3 is called columella because it resembles the middle ear of birds. They have a single ossicle. Type 6 is not part of original Zollner-Wallstein classification. It is a recent addition. Next case is a 30-year-old man presents with complaints of painless, odorless and profuse discharge from the left ear. Otoscopic image showed medium central perforation of the pars tensa, which is suggestive of tubotympanic type of CSOM. Canal wall down mastoidectomy is not a part of management plan. This is only performed in atticoantral type and in cases of tubotympanic type where a reservoir of infection in the middle ear is suspected. Management of tubotympanic type of CSOM is medical management, which includes oral toilet, topical antibiotics with steroid drops, systemic antibiotics, and treatment of causative factors. Surgical management is done once the ear is dry for 6 weeks without antibiotics. Tympanoplasty, that is ossiculoplasty with or without meringoplasty. Temporalis fascia is the most common graft material used for tympanoplasty. Other graft materials used are the areolar fascia overlying the temporal fascia, perichondrium from the tragus, conchal cartilage, vein, periosteum. Dura mater was used earlier but then discontinued due to the risk of prion diseases like Creutzfeldt-Jakob disease. Next case is a patient having chronic otitis media with perforation of pars tensa is scheduled for meringoplasty to restore hearing. In the underlay technique, the graft is placed medial to the annulus, whereas in the overlay technique, the graft is placed lateral to the annulus. The graft is medial to malleus in both techniques. Meringoplasty techniques are based on the relation of the graft with lamina propria of tympanic membrane remnants and fibrous annulus. Next case is a patient with mucosal disease of the middle ear is said to undergo meringoplasty. In this case, Weil's incision or post-oral incision is used in meringoplasty. Weil's incision is used in the following like cortical mastoidectomy, modified radical mastoidectomy, tympanoplasty when perforation extends anterior to handle of malleus, and Weil's incision is used in the exposure of cranial nerve 7 in the vertical segment, and it is also put in the surgery of endolymphatic sac. Austin's classification of anatomical defects in the ossicular chain is based on the presence or absence of handle of malleus and stapes suprastructure. Incus is the most common bone to be eroded, and assuming it to be absent in most cases, the remaining two ossicles, that is malleus and stapes, are considered for the classification. Austin's classification in detail based on the presence or absence of malleus handle and stapes suprastructure, assuming incus is absent in all cases. Austin's classification include type A, type B, type C and type D. In type A, Austin's classification, malleus handle present, stapes superstructure present. Reconstruction is partial ossicular reconstruction prosthesis is placed. In type B, malleus handle present, stapes superstructure not present. Reconstruction is total ossicular reconstruction prosthesis is put. In type C, Austin's classification, malleus handle not present, stapes superstructure present. Reconstruction is partial ossicular reconstruction prosthesis put. In type D Austin's classification, malleus handle not present, stepy superstructure not present, reconstruction is total ossicular reconstruction prosthesis is put. Next case is a patient presents to your OPD with hearing difficulty and scanty foul smelling discharge from the left ear. Otological findings showed fleshy red polyps as well as granulations, cholesteatoma present. Discharge is scanty, purulent, foul smelling and blood stained. The given clinical scenario describes a case of atticoantral type of CSOM and modified radical mastoidectomy is the treatment of choice. Myringotomy is done in case of ASOM and serous otitis media. Medical management followed by myringoplasty or tympanoplasty once the ear is dry for 6 weeks without antibiotics is the treatment of choice for tubotympanic type of CSOM. Next case is a 7-year-old child presented with scanty foul-smelling ear discharge. Otologic examination showed marginal perforation which is suggestive of atticoantral type of CSOM and the appropriate management plan is surgical intervention with tympanomastoid exploration. A patient presented with otoscopic finding that is a white mass located in the anterosuperior quadrant behind the intact eardrum which is suggestive of cholesteatoma. The primary aim is to clear the disease and render the ear safe. The second priority is to preserve or reconstruct the hearing but never at the cost of primary aim. Next case is a 12-year-old child with CSOM and cholesteatoma is planned for a mastoidectomy. He is a part of school swimming club and wants to pursue the sport. So the question here is, which of the following would you mention while counseling the parents regarding canal wall up and canal wall down mastoidectomies? So here the answer is post-surgery healing is rapid and periodic cleaning is unnecessary in case of canal wall up procedure. This procedure has a low predisposition to infection but carries the risk of leaving behind residual disease requiring the need for second look surgery. In detail about canal wall up procedure, meatus appears normal, does not require routine cleaning, high rate of recurrent or residual cholesteatoma, requires second look surgery after 6 months, the patient is allowed to swim, no limitation, easy to wear a hearing aid if needed. In detail about canal wall down procedure, here the meatus opening is wide, communication with mastoid, cleaning once or twice a year is required, low rate of recurrence, second look surgery is not required here, swimming can lead to infection of the mastoid cavity, problems in fitting a hearing aid due to a large meatus and mastoid cavity is seen here. Battle sign refers to the retroauricular or mastoid ecchymosis that typically results from fracture of the middle cranial fossa following head trauma. It is prominent when there is a fracture of the temporal bone. Battle sign is not seen in case of otitis media. Bizolt abscess is a complication of acute otomastoiditis where the infection or pus breaks through the thin medial side of the tip of mastoid and presents as a swelling in the upper part of neck. Grisinger sign is referred to the edema of the post-auricular soft tissues overlying the mastoid process as a result of thrombosis of the mastoid emissary vein seen in sigmoid sinus thrombosis. It is a complication of acute otomastoiditis. Typical delta sign is a CT finding which is seen in sigmoid sinus thrombosis, that is lateral sinus thrombophlebitis. CECT in sigmoid sinus thrombosis shows a typical delta sign, that is it is a triangular area with rim enhancement and the central low density area which is seen in the posterior cranial fossa on axial cuts. MR venography is useful to assess the progression or resolution of thrombus. Next case is a patient complains of severe pain in his right ear associated with high-grade fever and profuse ear discharge. Clinical examination reveals mastoid tenderness and perforation of the tympanic membrane. The clinical scenario of severe pain in his right ear associated with high-grade fever, profuse ear discharge, mastoid tenderness and perforation of the tympanic membrane is suggestive of acute mastoiditis, which has most likely occurred as a complication of acute infection of the middle ear. If this infection is to burst out through the medial side of the tip of mastoid, it results in formation of Bizolt abscess. Acute mastoiditis is used to refer to an acute infection that spreads from the mucosa lining the mastoid air cells to involve the bony walls of the mastoid air cell system. Blood leukocytes and ESR is raised here. CT scan of the temporal bone shows clouding of air cells due to collection of exudate in them. In later stages, a cavity may be seen in the mastoid. Treatment is done by administration of intravenous antibiotics and, if indicated, surgical procedures such as myringotomy and cortical mastoidectomy should be done. Abscesses in relation to mastoid infection are biseaules abscess, which lies deep to the sternocleidomastoid and presents as a swelling in the tip of the mastoid or the angle of the jaw, and it is seen in the upper part of posterior triangle or the parapharyngeal space. Other abscesses in relation to mastoid infection are post-auricular abscess. It is the most common abscess that forms over the mastoid. In infants and children, this presents over the McEwen's triangle. Next is zygomatic abscess. This is infection of zygomatic air cells. It is situated at the posterior root of the zygoma. Next is luke abscess or meatal abscess. The pus breaks through the bony wall between the mastoid antrum and external auditory meatus, causing luke abscess or meatal abscess. Next is Citylis abscess. The abscess is formed posterior to the mastoid, occupying a position more towards the occipital bone. Next case is a 30-year-old woman presented with history of ear discharge in the left ear for the past 4 weeks, deep-seated ear pain for past 1 week, and diplopia for the past 2 days. The given clinical scenario is suggestive of Great Nygaard syndrome, which occurs secondary to petrous appendicitis. This is a complication of otitis media. The triad of Great Nygaard syndrome consists of ipsilateral abducens nerve palsy, that is 6th nerve palsy, which causes external rectus palsy. Next is deep ear or facial pain, that is 5th nerve involvement. Next is persistent ear discharge, that is otitis media. These all are the triad of Great Nygaard syndrome. The incidence of this syndrome has reduced with the advent of antibiotics. Signs of atticoantral disease is pain, vertigo, persistent headache, facial weakness, fever, nausea or vomiting, neck rigidity, diplopia, ataxia, and abscess around ear. Pain can cause extradural complication, perisinus as well as brain abscess. Vertigo can cause labyrinthine fistula as well as labyrinthitis. Persistent headache can cause intracranial complication. Facial weakness can cause facial paralysis. Fever can cause intracranial complication. Nausea or vomiting can cause intracranial complication. Neck rigidity can cause meningitis. Diplopia can cause Great Nygaard syndrome or petrous appendicitis. Ataxia can cause labyrinthitis, cerebellar abscess. Abscess around ear can cause mastoiditis. Greisinger's sign is seen in sigmoid sinus thrombosis. It is described as mastoid tenderness and edema, which is secondary to thrombophlebitis of mastoid emissary vein. However, Great Nygaard syndrome or triad is a complication of otitis media, and it is seen when the infection extends to petrous apex, that is petrositis. The triad consists of ipsilateral abducens nerve palsy, deep ear or facial pain, and persistent ear discharge. Next case is a patient with a history of foul-smelling ear discharge for which he did not complete treatment now presents with complaints of fever with chills and swelling over the mastoid. On examination, there is tenderness along the jugular vein. The given clinical scenario is suggestive of lateral sinus thrombophlebitis. It is an inflammation of the inner wall of the lateral venous sinus with the formation of an intrasinus thrombus. Clinical features of lateral sinus thrombophlebitis are hectic picket fence fever with chills and rigors. This is due to septicemia. The clinical picture resembles malaria but lacks regularity. Next is headache. In the early stage, it may be due to perisinus abscess and it's mild. Later, it may be severe when intracranial pressure rises due to venous obstruction. Next is Greisinger's sign. This is due to thrombosis of the mastoid emissary vein. Edema appears over the posterior part of the mastoid. Next is papilledema. Its presence depends on obstruction to venous return. It is often seen with the right sinus, which is larger than the left. Next is tenderness along the jugular vein. This is seen when thrombophlebitis extends along the jugular vein. They may be associated enlargement and inflammation of the jugular chain of lymph nodes and torticollis. Investigation of lateral sinus thrombophlebitis include blood culture, CSF analysis, X-ray mastoid as well as CECT. On CSF analysis, it shows normal except for increased CSF pressure that helps in ruling out meningitis. X-ray mastoid shows clouding of ASL seen in acute mastoiditis. Destruction of bone is seen in cholesteatoma. CECT shows typical delta sign. Treatment of lateral sinus thrombophlebitis include intravenous antibacterial therapy, mastoidectomy and exposure of sinus, ligation of internal jugular vein as well as anticoagulant therapy. Next case is a patient with hearing loss has the following otoscopic finding, that is cherry red small mass of granulation tissue arising from the pars flaccida of the left tympanic membrane, strongly suggesting that there is an underlying cholesteatoma in the attic area. Surgery is the treatment of choice in case of cholesteatoma. The continuing discharge from the granulation tissue has caused the surface epithelia of the tympanic membrane to become edematous and thickened. This gives the surface of the tympanic membrane a thickened whitish appearance. The primary aim in surgical treatment is to remove the disease and render the ear safe, and second in priority is to preserve or reconstruct hearing, but never at the cost of primary aim. Mastoidectomy is done. Otosclerosis affects the otic capsule. The otic capsule is the dense bony labyrinth of the inner ear that surrounds the cochlea, the vestibule, and the semicircular canals. In otosclerosis, one or more foci of irregularly laid spongy bone replace part of the normally dense bone. The inner ear is divided into membranous labyrinth, which is also known as otic labyrinth. It is filled with endolymph. The bony labyrinth, which is also called as otic capsule, and next is periotic labyrinth, which is the space between the bony and membranous labyrinth, and it is filled with perilymph. So the inner ear is divided into membranous labyrinth, bony labyrinth as well as periotic labyrinth. Otosclerosis affects the enchondral layer of the otic capsule. Within the enchondral layer, there are sometimes islands of unossified cartilage rest that later give rise to otosclerosis. The otic capsule is made of three layers, that is endosteal, enchondral as well as periosteal. Endosteal layer is the innermost layer. Enchondral layer is the middle layer which is derived from cartilage that ossifies, and periosteal layer is the outermost layer. The most common site of origin of otosclerosis is the fissula antifenestrum lying in front of the oval window. It is seen in the stapedial type of otosclerosis. Types of otosclerosis are stapedial, cochlear, and histological. Stapedial otosclerosis is the most common type of otosclerosis. The otosclerotic focus is biscuit type when the disease process involves the entire foot plate except for the annular ligament. The otosclerotic foci in the stapedial type of otosclerosis can be of various types. First is anterior focus, that is, it involves only the fissula antifenestrum. Next is posterior focus, which involves only the fissula posterior fenestrum. Next is circumferential, which affects the margin of the foot plate only, that is annular ligament alone. Next is biscuit type, which affects the entire foot plate except for the annular ligament. Next is obliterative, which affects the entire foot plate and its annular ligament. Next is a case presentation. You are an OBG resident and your patient is one of your staff nurse. She is a primary gravida who has just been diagnosed with otosclerosis and wants to know its inheritance pattern. So the answer here is otosclerosis has an autosomal dominant type of inheritance. About 50% of the cases of otosclerosis have a positive family history, while the rest are sporadic. Genetic studies reveal that it is an autosomal dominant trait with incomplete penetrance and variable expressivity. Next case is for research on pharmacological treatment in otosclerosis. A researcher wanted to set the age limit of the study to the most common age group when the hearing loss usually manifests. In this case, the most common age group when the hearing loss in otosclerosis usually manifests is 20 to 30 years of age. It is rare before 10 and after 40 years. HRCT shows the double ring sign in cochlear otosclerosis, not in the stapedial type. Otosclerosis affects females twice as often as males, but in India, otosclerosis seems to predominate in males. Stepidotomy is contraindicated in children because recurrent eustachian tube dysfunction is common in them. This can displace the prosthesis or cause acute otitis media. Measles RNA has been found in otosclerotic foci, implicating its possible role in pathogenesis. Presbycusis is not seen in otosclerosis. The following hearing defects are seen in otosclerosis. They are painless progressive bilateral conductive hearing loss most commonly, sensorineural hearing loss which may be seen in cochlear type of otosclerosis, and paracusis willisii, that is patient hears better in noisy surroundings as other people raise their voice to be heard. Next case is in a stapedectomy specimen of a patient with otosclerosis, a pathologist noted that a few areas of the otic capsule appeared more basophilic than normal. So in this case, the blue mantle sign of Manasseh is a histopathological finding seen in otosclerosis. On histopathological examination of an otosclerotic foci, the osteoblast and osteoclast lie in an abundance of cement substance which stains blue with hematoxylin and eosin stain. Blue dot sign is seen in the torsion of the testicular appendage. Blue cement sign and islets in ocean sign do not exist. Next is a case. A 30-year-old Caucasian woman came with history of progressive hearing impairment which improves in a noisy environment. Tuning fork test revealed a conductive hearing loss in both ears. Otoscopic finding is normal tympanic membrane. There is bilateral conductive deafness, paracusis willisii, and a normal tympanic membrane which suggests a diagnosis of otosclerosis with matured focus. Paracusis willisii is patient hears better in noisy surroundings as other people raise their voice to be heard. The tympanic membrane has a normal appearance in most cases. This is indicative of a matured or inactive focus of otosclerotic bone. A case of CSOM will have a perforated tympanic membrane. Otosclerosis with an active focus will show the Schwartz sign. In the case of otitis media with effusion in the tympanic membrane is often dull and opaque with loss of light reflex. Next case is a 20-year-old female patient presents with features of bilateral conductive hearing loss not associated with tinnitus. Otoscopic finding is both tympanic membranes show Schwartz sign. This finding, along with the history of bilateral conductive deafness, is seen in active otosclerosis. A reddish hue may be seen on the promontory through the tympanic membrane, which is known as Schwartz sign. This is indicative of an active focus with increased vascularity. The tympanic membrane is quite normal and mobile. Rising sun sign is seen in glomus tumor. Setting sun sign is an eye sign seen in hydrocephalus. Cartwheel appearance is seen in acute suppurative otitis media. Next case is an ENT senior resident posted in a remote village comes across a patient in whom he suspects otosclerosis. In this case, Gellies is a tuning fork test done to clinically confirm otosclerosis in the olden days. It is based on the fact that in a normal ear, if pressure is increased in the external ear, the stapes footplate will get medialized and will stop conducting sound. But in an ear with otosclerosis of the footplate, there will be no movements and the patient will continue to hear the sound. Thus, Gelli's test is considered positive in normal persons and in those with sensorineural hearing loss. It is negative when the ossicular chain is fixed or disconnected. Stenger's test is done to rule out malingering. Schwabach is a tuning fork test that compares the bone conduction of the patient with that of the examiner. Rinne's is a tuning fork test that compares bone conduction with air conduction. The symptoms in the triad of van der Hoef syndrome is osteogenesis imperfecta, otosclerosis, and blue sclera. Next case is a 25-year-old woman with a family history of hearing loss in her mother developed a hearing problem during pregnancy. Hearing loss is bilateral and progressive. The above clinical scenario is suggestive of otosclerosis, and the single best investigation to diagnose otosclerosis is impedance audiometry. In pure tone audiometry, Carhart's notch with an airborne gap is indicative of otosclerosis. HRCT will show a double ring sign in cochlear otosclerosis, and it is not routinely done. Schwabach's test is a tuning fork test which will show conductive hearing loss. Carhart's notch typically dips at 2000 Hz in bone conduction. Pure tone audiometry in otosclerosis shows air conduction which is poor and worse for lower frequencies, bone conduction which is normal. There is a large airborne gap. In some cases, there is a dip in the bone conduction curve. It is different at different frequencies, but the maximum dip is at 2000 Hz and it is known as Carhart's notch. Boiler's notch is a similar dip in bone conduction and air conduction curve, but at 4000 Hz seen in noise-induced hearing loss. Next case is an elderly woman with history of otosclerosis has now come with worsening deafness. She attained menopause 1 year ago. The above case is suggestive of long-standing case of otosclerosis, and impedance audiometry will show AS graph and loss of stapedial reflex as a result of fixation of ossicles. Impedance audiometer measures two parameters in the middle ear, that is tympanogram as well as stapedial reflex. Tympanogram is type AS, which is seen in otosclerosis due to decreased compliance at or near ambient air pressure. Next is stapedial reflex, that is, it is lost due to immobile ossicles. Next case is a patient was diagnosed with otosclerosis and Schwartz sign was positive on otoscopy. Sodium fluoride is used in the medical management of otosclerosis. This is an active case of otosclerosis evidenced by Schwartz sign, and in an active case of otosclerosis, medical management is preferred. Surgery is contraindicated if Schwartz sign is positive. What is Schwartz sign? It is a reddish hue which is seen on the promontory through the tympanic membrane. This is indicative of an active focus with increased vascularity. In an active case of otosclerosis, medical management with sodium fluoride is preferred because sodium fluoride hastens the maturity of active focus in otosclerosis. It acts by inhibiting the osteoclast and decreasing the proteolytic enzymes. Next case is a 25-year-old woman presents with bilateral progressive conductive hearing loss. On examination, the tympanic membrane is normal and the audiogram shows bilateral conductive deafness. Impedance audiometry shows AS type of curve and acoustic reflexes are absent. The above clinical scenario of bilateral progressive conductive deafness with AS type of tympanogram and absent acoustic reflexes is suggestive of otosclerosis. Gentamicin is not used in the management of otosclerosis. Medical management includes the use of sodium fluoride and bisphosphonates in active cases. Surgical management includes stapedectomy and stepidotomy, though the stepidotomy is preferred, which is due to decreased risk of fistula formation. Hearing aid may be used as an alternative to surgery. Next case is a primipara being evaluated for hearing impairment which had worsened during her pregnancy. Rinne's test is negative in both the ears and Weber's is lateralized to the right side. On otoscopy, tympanic membranes appear normal. Audiometry shows a dip in bone conduction at 2000 Hz. The above clinical scenario is suggestive of otosclerosis, and the treatment of choice for otosclerosis is stepidotomy. Stepidotomy is the excision of the superstructure of stapes and drilling a hole in the foot plate and placing a piston in the hole. This is the treatment of choice. Stapedectomy is the excision of the entire stapes, that is superstructure as well as foot plate, and placing a piston in its place. It is outdated. Sodium fluoride is used in an active case of otosclerosis to hasten maturation. Both stapedectomy and stepidotomy have been described for the treatment of otosclerosis. Even in the stapedectomy procedure, stepidotomy, that is drilling, has been practiced. Hence, stepidotomy is preferred over stapedectomy and it is considered as the treatment of choice. In the above case, since Rinne's test is negative on both ears, it indicates bilateral conductive deafness. Weber's test will lateralize to the ear with greater conductive loss. Next is a case You are assisting in a stepidotomy procedure for a patient with otosclerosis. The piston is placed between the incus and oval window. Stepidotomy is done to bypass the immobile stapes using a piston which will take over the function of conducting sound. For this reason, the piston replaces the removed stapes superstructure. Next case is, you are an ENT surgeon and few patients with otosclerosis are coming in front of you, and in which case will you advise stepidotomy? The cases are a factory worker with no other comorbidities, a 35-year-old male with Meniere's disease, a 28-year-old male commercial pilot, a 30-year-old female with bronchial asthma, a middle-aged man with diabetes and absent Schwartz sign. In which of the patients will you advise stepidotomy? So in this case, we should discuss about the contraindications for stepidotomy. Contraindications for stepidotomy are only hearing ear, positive Schwartz sign, otitis externa, Meniere's disease. Meniere's disease, that is, which can damage the inner ear while drilling a hole in the foot plate, and it is contraindicated in young children, in professional athletes, pilots, construction workers, drivers. That is, sudden change in pressure can displace the piston and causes vertigo, and it is stepidotomy is contraindicated in those who work in noisy surroundings. That is, surgery makes them more vulnerable to noise induced hearing loss. Next case is, an ENT surgeon has referred a patient with otosclerosis posted for stepidotomy to your anesthesia OPD. She has no known comorbidities. In this case, stepidotomy is preferred to be done under local anesthesia because damage to the facial nerve can be checked, damage to inner ear can be assessed by the patient's symptom of vertigo or nystagmus, immediate on-table improvement of hearing can be assessed. Next case is, in a patient with otosclerosis who underwent stepidotomy, cholesteatoma is not a complication of stepidotomy. Next is in detail about the complications of stepidotomy: sensorineural hearing loss, injury to facial nerve, floating or submerged foot plate, endolymph gush due to damage to inner ear, dislodgement of piston, post-operative vertigo, and dead ear. These all are the complications of stepidotomy. Next case is, in Lambert's fenestration, an alternative window is created in lateral semicircular canal. This is because Lamberton's fenestration, which is an alternative window which is created in the lateral semicircular canal, is to function for the obliterated oval window. Lambert's fenestration operation for otosclerosis is outdated now. It has the disadvantage of a post-operative mastoid cavity and an inherited hearing loss of 25 decibel which cannot be corrected.